previous board secretary. Welcome to this public board meeting. I'm Emma Woollett, and I'm delighted to be here. Are we live streaming already? We are? Fantastic. Excellent. So the first thing to say is I'm delighted to have been appointed as chair of NHS Lancashire and South Cumbria Integrated Care Board. I do think the ICB has got some really clear vision and strong ambitions, also significant challenges, as have we everywhere across the NHS. But we want to improve quality, transform care in the community, and address the challenges that the NHS faces. And I'm really looking forward to meeting those challenges with everyone around this table and beyond. I'm looking forward to meeting many new colleagues. I've met lots of people today, but I'm looking forward to doing that more substantively as my term starts to take place. I would also like to take this opportunity to thank Roy Fisher, who has stepped up so ably over the last 6 months, actually, into the chair position during the interim period. And I'm very, very grateful to you, Roy, and you're also helping me significantly as I slip into the position as well. So I'm going to start the board properly now. If I can, I'll start with apologies and introductions. We've got apologies from Denise Park, who's the local authority partner member, but the meeting is quorate. Sarah O'Brien has invited Ruth Keeler, who is the strategic lead for careers and apprenticeships for the ICB, to shadow her at this board meeting. So welcome to you, Ruth. Are you sitting in the... She's not yet here. Okay, that's fine. And we also have big welcome to members of the public. It's a really important thing that we are publicly accountable, and it's good to see so many members of the public and I think our staff here today. The agenda today is a relatively light one, and therefore I'd like, there is opportunity to sort of probe things. But I think it's fair to say that I would like to make sure that we keep the agenda as we go forward as informative and interesting as possible, that we don't just talk about box ticking and process, but that we do talk about what you're here to hear, which is about how we're going to reduce inequalities, transform the care across the system, and spend the taxpayers' money wisely. Okay, so I want to maximise our time for discussion today, so I do ask the executives to keep introductions of items brief. And we've got two significant items to consider for approval. One is the 5-year urgent and emergency care strategy, which of course is really important from both a quality, efficiency and patient experience perspective. We start the board meeting with a patient story, and for today's patient story we will hear Melanie sharing the story of her husband Chris, who was a nurse and who very sadly died from an unmonitored heart condition. Sarah will introduce the story, which has clear links to the 5-year strategy that we're going to talk about later, and I'm pleased that we've got that. Following the board meeting today, the ICB is holding its annual general meeting. That's going to be from 4:30 to 6 p.m. The ICB's annual report and accounts for 23-24 will be presented, and anyone that is observing the board meeting today is more than welcome to join us at that. We've received a question pertaining to remarks in the Chief Executive's report last time about the bleak financial situation and the commitment to recovery and transformation. And the question asks whether it's possible to indicate whether increased resources can be provided for prevention measures as a feature of transformation. Kevin will address this largely in his Chief Executive's report, but be assured this is something that we are, it's fundamental to the conversations that we're having, is how we balance the financial imperatives, and we are a system that is significantly in deficit, with not allowing that to distract and divert us from our ambition to improve patient care and increase prevention and increase care in the community. So that is going to be a theme and is a theme in all our meetings. Okay, so on to the more formal stuff. Declarations of interest. I haven't had any, been informed of any conflicts or declarations of interest. Is there anything for today's meeting? No, excellent. So, on to the agenda, the minutes of the board meeting held on the 17th of July. First of all, can I just be sure that board members are happy with the minutes as they stand? I think there was one amendment that was made that's been put through. Are the board members happy it's an accurate record? Excellent, thank you. Any matters arising that don't feature in the action log? No, excellent. So all the matters arising, I think, in the actions are captured on the log, and updates have been provided, and I've got them here. So a number of them are dates which we will get in the diary. I'd quite like to get this action log shortened, actually, because I think a lot of these things we should have dates in the diary, which we will do. Debbie, Deborah, is there anything that you would particularly draw board members' attention to in terms of the actions? It's difficult for me because I wasn't here.
So the commissioning intentions paper to the September.
Oh, that is going to come to October board. November board, in fact. November board, yes.
And there was just a question as to whether there is a comment that came out of the discussion around the EDI strategy, and whether actually that could be
yes,
deferred to the people committee to pick
yep.
that action up in more detail.
Yeah, I think that would be appropriate. If we're happy, yeah. And otherwise, I think there are dates that need to go into the diary. So with next meeting, I'd expect this to be have just the actions from today. Excellent. So we now move to the report of the Chief Executive. Over to you, Kevin.
Just might say a couple of words.
Of course.
Okay, thank you. Thanks, Chair. I'd just like to say a huge thank you to you for your very kind remarks earlier. And for my tenure of the board for the last 6 months, I'd particularly like to thank members of the board for your help, your advice and your support. Specifically the executive members of the ICB and the NEDs, who have been a great help to me, and I would wish that to be put on record. So thank you so much for everyone for your kind support. Thank you.
Thank you, Roy.
Okay. Good afternoon, everyone. Just like to make a few remarks, if I may. First area will be around the financial challenges we're facing across the NHS as a whole, but particularly in Lancashire and South Cumbria. I think it is worth drawing on the wisdom of Nelson Mandela and his comments. It always seems impossible until it's done. So it's about, in these difficult times, really being relentlessly positive and optimistic. I think that's really, really important. We did have a major group of legacy issues that we've inherited, but it's our duty to face up to those challenges. And there are still amazing opportunities before us, and it's our duty to exploit those opportunities going forward as well, isn't it? So that's really the crux of what we need to do there. Find a way of seeing this all as an opportunity. We are one of 20 systems in the country that are receiving NHS support to help us through this process. So we are using PA consulting and some other outside help as well. So it's worth noting that. So that's the first thing. The second area is the Southport tragedy, a horrific event. Staff from our system were involved in that response, and you know, they deserve our thanks for, you know, what was a very, very difficult few days. And we also had the aftermath of Southport as well, and a lot of staff were subject to incidents of racism. So just want to make clear that we're not going to tolerate that going forward. Fortunately, things seem to have calmed down significantly since, but it was a very difficult episode that was right on our border. Third thing, more positively, We've got a number of HSJ award entries in the Lancashire and South Cumbria system, so wish all of them well, and Chris, LSCFT are up for Trust of the Year, so good luck for that as well. And finally, I'd like to mention, before I deal with a public question, we have our new Chief People Officer, Debbie Airteo, I hope I got that right, who is here today, and she'll be starting next Wednesday, so looking forward to that. So Michael Wedgeworth submitted a public question which was about some of the remarks I made in my last report. So this was about the bleak financial situation and the commitment to recovery and transformation, and if it is possible to indicate whether increased resources can be provided for prevention measures as a feature of transformation. That's the gist of it. It is one of the jobs of the ICB, isn't it, to look at the wider determinants and move, not to be too much into jargon, move upstream. This is a really important part of the ICB's mission. We are at the same time in a very challenged situation financially, so there won't be any extra money. Overall, there's less money really when you consider inflation and convergence funding. But there are lots of opportunities to realign our spending from our base budgets, and we do need to do that and give priority to the prevention agenda. And I thought I would highlight two simple examples to illustrate that. One is hypertension, blood pressure. There's been a major program on hypertension for the target group that we've been focused on. We've moved in a year from 60% to 72.6%. Now the national target is 77, but we're making steady progress towards that. That's a real success story. More to do. So that's one area. The other area is around urgent emergency care. It's topical because it's on the agenda today. We've seen a very significant increase in presentations to accident emergency across the whole system. We are a national outlier in this. There is a real serious risk it overwhelms the acute sector. So we've been working very hard across the whole system with both social care, with primary care, and with colleagues in the acute sector to have joined up UEC plans, and a key part of that is a real strong focus on admission avoidance. So that's another great example. So it is challenging. It is a key priority area for the ICB, and we have to look at our core budgets and see the extent to which we can realign them and give more priority to prevention, and probably recognise that we can't do everything, pick a few things and really go for them. So that's, I hope that's helpful, Michael.
Thank you, Kevin. Does anyone have any questions for Kevin? Yes, so I've got...
Not a question, just an observation, Chair. We're very happy as part of, as a participant member and from a local government family, and on behalf of the Directors of Public Health, just wanted to express the intention and willingness to work with Kevin and the exec team and the board to realign the budgets that are core baseline budgets, so we can take some practical, demonstrable steps towards more investment in prevention, which will overall help not just the urgent emergency care system, but also improve the outcomes and reducing health inequalities, which are the key aims of the board as well. Thank you.
Thank you. And Tracy.
Thank you, Chair. Yeah, I just wanted to say how pleased I was to see that the endorsement of the Gambling Harms Workplace Charter is in your report, Kevin. As somebody who's a leader in the VCFSE sector, but also runs debt advice services in Blackpool, we're absolutely aware of the way in which gambling harms are affecting people's health. You know, a huge increase since COVID, and I think a really important step to say actually we recognise this as an organisation, and we want to sign a workplace charter to say we'll support our staff. We know the links between health inequalities, gambling, and you know, mental health, and we're seeing that that first hand on the ground, but also I think the stigma attached to gambling and gambling harms, I think by bringing it in, putting it in your report, making it visible is a really good step to start tackling some of that stigma. So thank you for that.
Thanks, Tracy. Any other thoughts? No? Okay, that's great, thank you. So we now move to the patient's story. So I'm going to hand over to Sarah to introduce this.
Thank you, Chair. So just to set the scene, we're going to watch a video in a minute which is told by the wife of a patient who tragically died, and she'll relate to you the experience he had, which unfortunately over the last few years before he died, I think what comes out in the video is how disjointed services were, even though there should have been connection. He was living with a long-term condition, and there should have been better working between primary care, specialists in secondary care, and also at the point when he got really unwell, the emergency response. So it brings out lots of themes, some of which are very pertinent to the urgent emergency care strategy that we're having later, but I think also whenever there's any incident or safeguarding review or anything in my experience, when we reflect on things that we could have done better, often a theme that comes out is how we join different parts of the system up, and I think this is another example of where the system didn't join up as well as it could have done from their perspective. And just to also put in context, often patients will write in with their experiences, and it's from their viewpoint, which this is, but actually this case also did go to coroner's court, and there was a coroner's verdict that there had been a failure of care for this gentleman. So I don't think there's not any debate that we didn't get everything right on this one. We didn't get things right, and I think it's really important as we listen to it, we keep in our minds this when we're going into later on the discussion around the urgent and emergency care strategy, but also some of the things in the Chief Exec report about the need for community services, and how we join everything up is really, really important.
My husband was called Christopher Graham. He was a mental health care practitioner and had heart problems which dated back a while. In 2016, he had his normal checkup with the cardiologist. The letter, which I've kept, recommends that Chris was able to access the service every 6 months for a checkup. He was on warfarin and went regularly for the warfarin checkups. A few years ago, he started with warfarin bleeds and also developed TIAs. Last year, he went to the GP after having had an TIA and was told that she would get in contact with the hospital and the hospital would get in contact with him. This never happened. On the evening of the 11th of March, he started with a cough, and he had cough, passed off, went to bed, slept okay, started coughing again, went downstairs in early morning, left me in bed asleep. My son heard him make a couple of sighs and alerted me. I went downstairs. He was lying on the settee, obviously had been listening to his iPad. I tried to rouse him, couldn't. Felt his pulse in his neck, it was racing, and then it went dead. We dialed 999, and in the meantime, while we waited for the ambulance to come, we did CPR, but I knew he'd gone. The paramedics, very good. They came within 10-15 minutes, worked on him, but he was pronounced dead about 40 minutes later. The coroner said, there'd been a failure of care and nothing had been done. Chris should have been monitored. It was during COVID. Hospital appointments were cancelled. We didn't see GPs. And I feel that he was let down by the system. He'd given his life to the system, and I felt that it had let him down when he needed it the most.
Very Powerful story. Any thoughts? Any comments from board members? And stories like this that make us remember really what we're trying to do and what we should be doing. Sorry, Kath.
Yes, thank you. So I just wonder, and I suppose the question is how isolated is that if we were all absolutely honest? And I think around the table and in the room, there are lots of people who've got their own lived experience. And I'd be doing myself a disservice if I didn't relate to my own experience. So I'm Kath Worley, I'm the Director of Adult Services, but I'm also Kath Worley, the daughter of a chap called Frank, who accesses care and healthcare and social care on our footprint. And that story resonates really strongly with me. So he has cancer, he has dementia, he has kidney problems. And every time it's 3 different stories. Nobody joins up the pieces. So I just wanted to relay that in because for me that's really important because it just resonates strongly, not just as a director of adult social care, but also as somebody who's got lived experience.
Thank you, Kath. Debbie.
Thanks, Emma. It's trying to understand what safeguards are in the system to be sort of assured really that it was isolated, hopefully, and sort of what we're doing to try and support services to have the capacity and the systems in place so that people don't fall between the cracks. So I'd just be interested really in terms of what we've put in place to be able to address the issue and the challenge.
Sarah?
Yeah, I'll try and respond. I suppose there's a couple of things, and listen to Kath. And I suppose one of the contexts there was COVID, and COVID was very difficult and very different. And actually, I lost my dad during COVID, and some of that really resonated with me because it was a similar scenario. However, unfortunately, I don't think it is an isolated case, I would say to you. And we know from lots of indicators, particularly when the system's overstretched, that, you know, and the patient experience team have recently done a piece of work evaluating quite a lot of our feedback around urgent and emergency care and some of these things. And so I can't assure you that was an isolated case because I think we all know that can be a challenge. However, what steps are we taking? Because clearly it's important we learn from it and we're putting things in place. And I think, you know, that's part of the driver behind the urgent and emergency care strategy. And we're not waiting for the strategists. Some of that work's already in train. One of the things I jotted down, which I think is a real one of the potential solutions to a gentleman like that, is virtual care. Not necessarily virtual ward, but you know, years ago you had to be monitored for things, and TIA is a transient ischemic attack, which is like mini strokes for anybody who wasn't sure what that was. But a long time ago the answer was going back up to an outpatient clinic every 6 months, but actually that really doesn't need to happen now. People living with long-term conditions can be monitored and checked in on quite effectively remotely and with virtual technology. And we've still got quite a long way to go, I think, in Lancashire and South Cumbria in terms of more routine long-term condition virtual monitoring, but we are doing work streams on that. So I think there's multiple things that we're doing, Debbie, that will address learning from cases like that. But I think the other part of it is to keep listening to stories like that, because it reminds us and it refocuses us on how important working together is and how important it is for families to be able to feedback and we listen to them, which I think we also don't do as well as we could do.
Thank you, Sarah. Jim?
Yeah, thanks. And thanks for the story. It's a really important reminder to all of us that these things are going on. I often feel helpless when we have these conversations, but it does feel like one of the solutions is around our digital and data strategy. And I know Asim brought our strategy to the board a few months back. I think we need to try and push ahead on that. It's not just in our gift, it's kind of what's going on nationally around apps and all those sort of things. But it feels like we really need to push forward on almost fail-safe systems somehow, because the more we can take the human contact bit out of this and have it relies upon systems, the more likely it is that we won't get these things falling between gaps. And digital and data strategy was pretty ambitious, so I think we need to make sure we keep an eye on that going forward and that it happens as quickly as possible, basically.
Thank you. Okay, so that's powerful story to ground us. Oh, sorry. Asim, yes.
Thank you, Chair. Just to come back on a couple of bits there, and I think I completely agree with Jim and Sarah. So long-term condition management, remote monitoring and heart condition. I think there's been 2021, there were 5 national demonstrator sites specifically around management of heart conditions. And there's been a lot of progress across the country, and Jim is right. I think we are somewhat behind the curve here and we need to catch up, and it's sort of really good to see that this is not just solely part of the digital data strategy, it's virtual care hubs are part of the UEC strategy and the emerging thinking of transforming care in the community. And it's not just the technology, it's the role of the hub in doing that coordination between different healthcare professionals. And that coordination role, I think, would have been really helpful in the patient story we've heard. So I just wanted to agree with the points made and just to reiterate the importance that we put on this agenda. Thank you.
Thank you, Asim. Okay, I'm now going to move on to the reporting from committees, which is the next agenda item. Each committee chair draws highlights and alerts. I'm going to start with Jim for the Audit Committee, please.
Thank you, Chairman. I'll just mention a couple of quick things if I could. The first one is that on the alert that's in the feedback from the Audit Committee relates to the assurance mapping exercise, and this is where the executive team looked at 18 areas and they assessed 7 as being of limited assurance. So from the Audit Committee, if something comes up limited assurance, we're looking for feedback on what's being done about it. So we're looking to get feedback on that to our December meeting. The executive team will be doing this anyway, and I think Deborah will be taking this exercise forward in conjunction with Sam as well. So that will be happening, and it's listed the areas there. And the other thing I'd perhaps quickly mention is under advise, we make reference to the proposed deep dive we're doing into all age continuing care. I'm very conscious there's an awful lot of people looking at all age continuing care, but if you look at the completed internal audits, 2 of the items listed relate to this subject, and the Audit Committee felt we've almost got a duty to make sure that what's going on is as effective as it should be. So we're going to do, it's deep dive may be overstretching it. We're going to look at it and see if the key problems are being addressed. That's all I want to say on that one, but I'm happy to take any questions.
Thanks, Jim. Any questions for Jim? No? Okay, so then I'm going to come to Sheena for Quality Committee.
Thank you. For those people who don't know me, I'm Sheena Comiskey. I'm one of the non-executive members, and I have the privilege of chairing the Quality Committee. And the triple A report is from our meeting that took place on the 24th of July. What I'll do is assume, as we should do, that members have had the opportunity to read the AAA report, and I'll just pull through some points from the alerts. So the first of those is around Lancashire Teaching Hospital and the fact that they are challenged around their rates of C. diff or C. difficile, which is Sarah will correct me on this is a transferable infectious disease. Thank you. That the Quality Committee will have looked at this as an alert to pull forward, but we just want to really emphasise that there's a full improvement plan in place with support from regional colleagues in helping in this area. The next item I just wanted to alert the board to was around the capacity to meet the growing demand for education, health and care plans. And this capacity challenge has been driven by the doubling of the demand for these plans, and as a result the capacity is struggling to keep up with this. But we are looking at work being progressed to respond to this, including streamlining the process, but really it is a very challenging area and something that we'll need to really keep a close working eye on and work particularly in partnership with other colleagues in the system on. The next item was around the thrombectomy and its provision of the weekend service for this again at Lancashire Teaching Hospitals, and work is being taken to address that. And David, I didn't warn you of this, but can you give us the latest update? I know you would have it. Thank you.
So for thrombectomy, yes, there was a rapid quality review that took place on the 4th of September. In fact, it was led by the regional team, and in fact involved 2 other providers of thrombectomy in the northwest, that is the Walton Hospital and Salford. The good news is that for thrombectomy that Lancs Teaching now have got a rota in place and runs 4 weekends out of 6, and for the other 2 weekends they are looking to those who provide that cover already to fill in some of the gaps. They also have a new consultant starting before Christmas and another one starting early in the spring. So hopefully that will all be sorted out and we'll be able to have a proper service running at last. Thank you.
Thank you, David. Do you want to pick up that now, or sorry, Emma?
Was this about thrombectomy? Let Sheena finish, and then I'll open up. Yeah.
Okay, and then the final alert I just want to bring board members' attention to is around sodium valproate. I can't get my tongue around anything today, so I do apologise to everybody. And it's about ensuring that all reviews follow the latest guidance, and we have got a working group, or there is a working group to focus on this, and it is an area that we will keep under review through the Quality Committee. And again, I think David might want to come in on that. Thank you.
Yes, because so first of all, for members of the board and the public, sodium valproate is a drug which is used to stop people having fits, typically. It's been found out in the last few years that unfortunately it's a drug that can cause, if a woman becomes pregnant, you could then have damage to the baby when it's born. Okay, so it's really important that these women, and in fact the men who take sodium valproate, are carefully managed. Lancs Teaching Hospital have been a little bit slow in responding to the alert that was sent out. The good news is that we've had some further discussions with them, and we may have identified some nurses from within the trust who would be able to support the patients as they go through the transfer from sodium valproate to something else. And again, we'll keep a careful eye on it through the meetings we have with the trust as well.
Thank you. Thanks, David. And then finally, in terms of just you'll note from having read the report that we, given the size of the agenda that we have for the Quality Committee, we had looked as a board, we'd looked to see in terms of our patterning of committees whether we could go to bi-monthly, and we have trialled that. And you'll know from our last report that we were considering whether that was how that was working, and as a consequence of the review we've reinstated our monthly meetings, and I think that just enables us to have the quality of discussion that we need, and to have the assurance that we would look to on behalf of the board, and I think that was all I wanted to say. Thank you, Chair.
Thank you. Thanks very much, Sheena. Any questions? Oh yes, there was Debbie first, and I think yep, great.
Thank you. So it's hazard of sitting in between colleagues who are talking and also sharing the same microphone and asking a question. I just wanted to ask a question around the Education, Health and Care Plans, the EHCPs. So I'm aware that EHCPs have a critical added value for young people and also parents who are either diagnosed with conditions or who need extra support ready to open up access, both in an HS setting and also an education setting. So I noted that part of the response is streamlining the processes so that hopefully more can be developed faster.
Yep.
I wondered if we're also looking at the quality of the EHCPs and the impact of them, and the ones that are produced, because it seems a great opportunity to look not only at volume but also quality. And also I wondered if we're able to explore the opportunity of having additional support in place ahead of an EHCP being agreed. So I know often parents and young people know themselves what they actually need. They don't need the EHCP to tell them that, but it's obviously helpful because it gives them more clarity and legal protection. I just wondered if there's an opportunity to free up some of that without the plans actually being in place, given that we've got that challenge.
Yeah. So thanks for that question. And I'm going to pass you over to Sarah, who clearly is a much better position to comment on this than I am. Thank you.
Chair. Yes, so in terms of streamlining, well, in terms of quality, it's our role anyway. The designated clinical officer's part of our role as the ICB is to oversee and quality assure the health aspects of the EHCP. So again, for colleagues who aren't aware, the education, health and care plan should be jointly agreed between health and where the statutory body in health who is responsible for that as an ICB, education, and often there's input from educational psychologists into those, but also the school or wherever the child is being educated would input, and social care. So the three statutory partners come together and make sure that EHCPs are not only timely and there are national targets around timeliness, but also that the quality, so we would assure the quality part of it. The challenge is the sheer volume, and so we aren't hitting our timeliness targets on many of these areas. And I have raised, Quality Committee is very cited on the risks around SEND, and it has come through here to board. I think it would be an area that would be valuable for board, particularly when we're looking at things through a health inequalities lens at any future meetings, to really think about this, because it is the area, I've raised it here a few times, where I have my most concern around waiting times, pathways, and some of this will come out in the performance report. So I do think it's an important area for board to be cited on the challenges across Lancashire. And the challenges are national, but we are particularly challenged in Lancashire and South Cumbria, not only on our AHCPs, but on our waiting times across these pathways at the moment.
Thank you, Sarah. Before I go, I've got Kath, and then I've got Sakthi, and then I've got Jim. But do I sense an action coming there? I've seen this send thing coming into board minutes before. Is this something that we ought to be having at board, or is this something for a committee? Would you say, Kevin or Deborah?
It does get scrutiny, doesn't it, at Quality Committee, but it's whether we feel that it needs a focus as a specific agenda item at board as part of the broader.
I think it would need to be part of a broader conversation. Sakthi, do you have a view on that?
Yes, I do, Emma, thank you. The perspective I'm coming is to support Sarah in what you said about challenges in the waiting times, but also opportunities in terms of how can we actually thrash some of those waiting times. Interestingly, in some districts, if you follow the child from when they show some concerns, parents are concerned, they get stuck in a speech and language clinic waiting time, and then it leads to delays, and the HCP plan becomes a need, and so on. In some districts, what we've done is working in collaboration with education partners and social care and health visitors and speech and language therapists. We've located some of the clinics into a common setting as a practice of innovation, and we've seen the waiting times reduced from 40 to 0. So when and if and when we are discussing this as a board, it is of relevance to discuss as a wider system, and to also look at different ways of working and innovating the models of care. So I think it warrants what Sarah just said. Thanks.
Sarah?
If I can add as well, and I agree with that, we are in the background at the moment doing quite an important and big piece of work around reviewing the neurodevelopment pathway end to end, because we know there's significant challenges, and the team will have ready by autumn a business case. So I wonder, and I think that will be something that will have to come to board, because it's probably going to require either some reallocation of resource or some investment to address the challenges. So it might be that we schedule that, and
yes,
at that board meeting, we have a focus on SEND as part of that paper coming.
That sounds ideal, and it would be good to get the wider opportunities and the wider system opportunities in that as well. Great, thank you very much. So I think it was Kath next.
Thank you, and I think it's just building on the idea of the broader conversation. So we're focusing primarily on the younger people, like when we're having the conversation about EHCPs, but there's a developing conversation nationally about what this increasing number of EHCPs is going to mean in terms of future demand for people entering into adult social care, for example. So we need to think differently about housing needs. How do we support those individuals? Culturally, are we making best use of the resources that we've got? Nobody sort of grows up with the ambition to go to a local authority day centre for the rest of their life. So actually, how are we engaging better, thinking about career opportunities for people and jobs that they may want to do? So I wonder if there's an opportunity, as well as trying to address the burning platform immediately, how do we be quite innovative in our conversation, pooling all of our brains and resources together to think about it on a lifelong opportunity. And I'd be really keen to be involved in something like that.
Anyone want to respond to that? Yeah, support it. No, excellent. Thank you. Thanks very much, Kath. Jim.
Thanks. Mine's a different issue. The learning from patient safety events note, which says that the national system isn't fit for purpose. As a strong advocate of learning from patient safety events, I was just wondering how concerned we should be about that, and at what point is this all going to be resolved and sorted out?
Sarah, could you pick that up? Thank you.
Yeah, I think, I don't think we are overly concerned. I suppose the bigger challenge at the moment, and our two provider partners might want to comment, is the fact that teams are having to dual report. So from a capacity point of view, at a time when there's lots of other things to do, that's a burden on the providers. But unfortunately, it's not in our gift to sort it out, because it's a national system and the national team are working on it. And I think we're reassured enough that it will come. It's more the burden it adds right now because of the dual reporting nature that governance or patient safety teams within the providers are having to do. But they are mitigating the risk of that system, but the mitigation is adding a burden really to operational teams, is what I would say, Jim.
I'm seeing nods from both provider chief execs there, so that's fine. Thanks, Jim. Any other questions for Sheena? Nope, then I think we will move to Jim and Finance and Performance Committee. The last one I think you're going to do, isn't it, Jim? Are you handing back to Roy?
Yes, I'm hoping so. It's been very enjoyable being the acting chair of the Finance and Performance Committee during a very challenging time. As it turns out, the main items we talked about were finance and the urgent and emergency care, and both are on today's agenda, so I'm not going to go into any great detail. Both are very challenging. There are issues around the pace at which we're kind of implementing what we need to do, but I think we'll be picking that up later in the agenda, so I won't go into any detail unless people want to ask me about what went on at the committee meeting.
No, thanks. Any questions for Jim? No, excellent. Okay, so we will move to Debbie on the Primary Care Commissioning Committee.
Thank you, Chair. So just a couple of items to draw out for attention. There's no items for alert from the last Primary Care Commissioning Committee meeting at the end of August. So a couple of points just to sort of to mention. We have 5 subgroups that look at the 5 delegated budgets that the commissioning committee has responsibility for, and we've completed a review of the responsibilities just to ensure that they're as streamlined as possible, but there's assurance there in terms of the work that's being done. So there were some adjustments made there, which I think is positive, given that we've sort of just completed almost the first year of the committee's operation that we're making those changes. Another couple of quick points under Assure, so Community Pharmacy Assurance Framework. It was just to mention to the board that there's been no pharmacies who failed their CPAF visits this year, and that there's been areas for small improvements identified that we'll be sharing and encouraging across other pharmacies, which is a really positive position to be in from a patient perspective. And then the Delivery Assurance End of Year report, we asked for a review of the contractual management of primary care contracts that have been undertaken in the past 12 months. So it was just to note that we received that. We've had assurance of the approach that's been taken, and we'll be adapting the approach moving forward just so that we've got more information around trends and patterns. Given that it's the first year, we've actually had the responsibility for the delegated budgets covered under the contracts.
Thanks, Debbie. Any questions on that? No? Okay. Jane, People Committee.
Thank you, Chair. Just to note that it is now People Committee, previously it was People Board. So we now have an updated terms of reference and membership. And we also had a discussion about diversity and inclusion and agreed those would sit within the remit of this committee. It is a system-wide committee trying to look at workforce issues across the system. So in that regard, one of the alerts is concerning because it concerns the VC FSC sector. And it was noted that not only are there shortages of capacity issues in terms of paid workforce members to take part in subgroups and so on, but actually the sector has experienced a decline in volunteers. And given how much we're relying on this kind of sector to support integrated system working, we felt that should be flagged to the board. Another alert was we had a presentation from the Social Care Training Hub, who provide lots of social care training, particularly for the independent sector, and their funding is coming to an end, so they're exploring other options for the future. Just to advise the board that we are going to have a focus looking at primary care. Given our strategy around community and primary care services, we feel it's really important that the People Committee looks at that from a workforce perspective, and people will have seen the issues around GPs and so on in the press, so we're going to have a deep look at that. In terms of assuring the board, just to note that a couple of things really. One, freedom to speak up is regularly reported in through the People Committee. The other one is for people to just understand that we now have 3 working groups taking the work forward. One is organisation, development and education. The second one is culture and inclusion, excuse me. And the third one is workforce insights, planning and transformation. So the idea is that the main committee will have a strategic focus, but that the subgroups will be focusing on implementation under those 3 headings. Just to note as well that all NHS system partners have signed up to an anti-racism framework, which we strongly supported, and we're keen, and it was also raised with other system members at the committee, to try and support rolling this out across sector organisations wider than NHS.
Thank you. Thanks, Jane. Anyone want to pick anything up? Questions? Yes, Tracy.
Thank you, Chair. Thank you, Jane, for mentioning the VCFSE workforce challenges. I think, as you said, it's really important when we consider the system workforce that we absolutely include VCFSE colleagues. I think a lot of the challenges we face as a sector mirrored across statutory sector partners, but absolutely the challenge around volunteering. I think also, and we're picking some of the things up later on the agenda around that integration and the importance and what we bring and the potential. But absolutely, there are many challenges that we're facing as a sector, financially around our workforce, and also around that flow of our workforce into the statutory sector as well. So I really appreciate that that is on the agenda for the People Board. One of the things that we are doing at the moment as a sector that I think is probably the board already have sight of this, but it's important to mention it at this point, is we're really getting under the skin and trying to understand exactly what contribution as a sector we make across health and care. So there's work happening at the moment around a state of a sector survey, which is quantifying some of this. So at some point in the future, I'd like to bring that back to the board again and pick up this debate about not just workforce, but that wider debate about what does it look like across Lancashire and South Cumbria as a VCFSE sector. Where are we making contributions? Where are some of those gaps? Thank you.
Thanks, Tracy. Roy, you wanted to come in?
Yeah. Did you want to come back?
Yeah,
okay,
fine.
thank you. Thanks, Chair. Yeah, just to welcome the look at the primary care workforce and GPs. I think particularly I would suggest as well you might look at the impact of nurse practitioners and physicians, that we now have in that workforce. And that's not a critical statement in any way. I think I would really welcome, the introduction of those into the workforce to help the GPs carrying out their tasks. And I found that personally has helped me significantly. I'm sure we've all been patients at some time. We'll all see these individuals. So I think if you could expand that, perhaps, I think it'd be really interesting to hear the ratio now of GPs to practitioners and to physicians. I would like to understand that as well. So if that could be included in your work as well, Jane, I think that would be welcomed by me. Thank you.
Thank you, Chair. Really important piece of work this around workforce planning, workforce transformation, and delighted with Debbie's appointment. I think if we think about the programmes of work we've mobilised across the system, whether it's the UEC strategy, transforming community care, the acute clinical configuration work, I'm just conscious that that is all pointing at how and where we deliver services. I think it's timely. Previously I brought a workforce strategy to the board, but the deployment of that, I think its shape is changing because of the transformation work that's being pulled together. I think it'd be really helpful if Debbie could help with the other Chief People Officers really consider, as part of our plans for next year and beyond, what that workforce transformation piece really looks like, because I think there's a lot of, for me, there's some value in there that we should be considering as a system, and I'm not quite sure we've got that coordinated view yet.
Thank you. David, are you coming in on this as well?
I am indeed.
Thank you.
Thank you. So, as we think about the workforce in primary care and it expands, and it's great we've got more nurses and pharmacists, the problem is we haven't got the estates in primary care. I'm not quite sure which committee picks that one up, but we actually got to the point now where we haven't got the room in primary care estates to put these people to do the work. So maybe, is that okay?
Yeah, it'd be Primary Care Commissioning Committee. We have recently had a capital workshop sort of looking at capacity issues and challenges and forward plans, and we've recently agreed this year's budget around capital, but we're working on a resource prioritisation framework for next year onwards. We're very happy to pick that up and report back.
Thank you. Left my thing on. Okay, excellent. So, Sarah.
Yeah, I just wanted to pick up on the social care training bit, because it's as an alert, but I suppose it's just a flag. They were funded through Health Education England, that now is part of the integrated NHS England, but and I know we've got absolutely no funding, but they do really, really invaluable work with the social care workforce. So that might be nurses working in social care, or non-registered nurses, but other staff working in social care. I've been to a number of their events over the last year, and it's such an important sector to it's a similar point really to the voluntary sector. This sector does so much invaluable work for us, and I think part of the answers and solution is how we integrate more, or how we grow that sector. And you can't really quantify the impact the social care training hub maybe have, but if we lose something like that, it's one of the things that supports that sector. It helps with recruitment and retention. And I just think we need to just really be mindful if we can't find a solution together on that funding, that will be a real challenge for us on that workforce, and will have unintended consequences potentially for recruitment into that sector, which can affect all sorts, like packages of care home placements, all of those things that statutory services use and would be lost without, really. So I know it was there as an alert, but we didn't really say a lot about it. But I think we just need to be mindful of that. I think that funding is essential for that work that they do.
Okay, thank you. So a number of related points, really, aren't they? And I'm going to crave the indulgence of being new to ask, workforce strategy across the system is the sort of key enabler for transformation, isn't it? And I'm sensing that we don't necessarily. Do we have one? Jane?
We do.
We do. Excellent.
We have a 5-year system-wide workforce strategy that's just about to go into implementation phase. So that should be the vehicle to deliver some of these actions that we need.
That's good. That's what I was looking for.
We
Good.
do have one.
Okay. Any other thoughts on that area? Thank you very much. So we now go back to Debbie for public involvement and engagement.
It's very quick because we haven't met since, so somebody has put it in as a header, but we're due to meet again towards the end of September. So I look forward to providing an update at the next meeting.
Thank you very much. That's great. So there won't be any questions on that. And finally, we have a verbal update from Craig on the North West Specialised Services Committee.
Thank you, Chair. So the September meeting was stood down. There had been a August seminar that I believe Jim attended on behalf of Langston South Cumbria, so might want to comment, but that was more a development session rather than any formal business. And we have had a Lancashire and South Cumbria Specialised Commissioning Oversight Group, of which unfortunately I wasn't at. David chaired, and the only element of alert was thrown back to me, which David's already updated on. So I don't think there's any substantial items to raise to the board today unless Jim's got any comments on the development session.
Thank you. Thanks, Craig. Jim, was there anything you wanted to add?
Just that the development session highlighted that the group is still developing, it's evolving. They were talking about the target operating model, they were talking about governance arrangements, and they're still being developed. The one bit of, I suppose, area they did talk about clinical area was retinopathy of prematurity, and that was around the funding arrangements and getting the equipment. So it is moving forward. The thing that has struck me being involved with it so far is this is a significant exercise. There's a lot of people working on this and doing a lot of work, and that's going to dig into the resources in this organisation as well. It's very important work, but it's probably a bigger venture than I thought it would be, frankly.
Yeah, David.
And the thing about SpecCom, and Jim is quite right, this is a big piece of work, one is the governance, and Deborah's been helping out with some of the governance. Now remember, the regional specialist commissioning team have not had a board to report to, and now they've got 3. And that really was very helpful to mention the board when we had the thrombectomy rapid quality review, because it means that we have to be able to report out to yourselves, and there has to be that public accountability, which sometimes has been lacking. And Deborah's been trying to help to align some of that governance, so as the quality work comes through, the alerts come through, the risk registers come through, we have that concordance across the whole of the Northwest. So it is big, and we just need to kind of, we're just trying to get it right.
Thanks, Deb. Thanks, David. And Sheena, you wanted to come in?
Yeah, I think just to really say, it is a big challenge, but it's also a huge opportunity, because it enables for the first time really that whole pathway. And you know, if we're really thinking about from a population perspective, and how do we start to get integration really to work and to move into the more preventative and early intervention, then actually having sight of the whole pathway for the population, I think really does help enable that wider picture. So, and it's really important also as we move forward into our further work on clinical strategy. So I think it is a lot of work, and it is a big picture, but I think actually it's a great opportunity. Thank you.
Thank you. Okay, so that concludes the work of the committees and shows quite how much work goes on between board meetings. I'm now going to move on to the business items of the day. The first item which is item 8 on the agenda, is the Integrated Performance Report. Asim, are you going to take us through this? Thank you.
Thank you, Chair. I think just to remind the board, the areas contained in the performance report are discussed in different forums across the provider organisations and within the structures of the Integrated Care Board. And the areas contained in the report are mainly NHS oversight framework statutory metrics. The report's in the May until July 2024, and although this is bang in the middle of the summer period, we do continue to see significant demand on our services. For example, the number of A&E attendances, which I'll cover later, were higher than the winter months. So with this increasing demand and pressure, our staff have remained steadfast in their commitment to deliver high-quality, patient-centred services. And for that, I would like to thank our frontline staff, whose dedication, resilience and professionalism is vital for delivery of our services. So I will take the report as read, but I will just highlight some of the key headline metrics. And starting with urgent care, the average Category 2 response time, the average and Category 2 is for urgent ambulance response for things like stroke, has been achieved again for July 2024. A North West Ambulance Service continues to maximise opportunities for hospital avoidance and diversion, and we saw again positive improvements in things like see and treat and patients being conveyed to another setting instead of A&E. But even with such initiatives such as hear and treat, see and treat, and diversion from non-E&E settings, we are seeing on month increases and pressures in our A&E departments. And once again, we saw an increase of 1,811 more attendances compared to the previous month. And when we compare this to the same time last year, we saw approximately 5,000 more attendances. So this is a trend that is increasing. So it's no longer seasonal and maybe pointing towards no longer winter pressures but year-long pressures. And later on, I'm sure Craig will touch on this in the urgent and emergency care strategy on how we continue to meet the demands of our population in this pressured environment. But saying that, despite these pressures, we have seen improvement on our for our A&E target. And I say this in most months, that the performance is better than the previous month. And I say this again, that in July we met our target of 78%. And for context, we rank 5th out of the 42 ICBs when it comes to for our targets. It's not the same picture for our 12-hour targets, and is a very variable picture where University Hospital Morecambe Bay performed really well, but Blackpool Teaching Hospital really pressured around the long wait. So I think that's an area we do need to focus on. Moving on to elective recovery, our waiting list stands currently at 241,753 patients waiting for treatment. And again, for context, before COVID, this was 120,000. So it's more than double people waiting for treatment. And before COVID, there were very few people that were waiting more than 18 weeks. So nationally, 7.62 million people are waiting. And over the last 6 months, we've seen a slight reduction in our waiting lists, where the national position has seen a small increase. There continues to be pressures in some of our services, around 78 plus week waiters, and in services like orthodontics and gynecology, that is putting pressure and risk around our targets around reducing long waiters. But when we look at metrics supporting elective recovery, we do perform really favourably compared to national position. For example, in our capped theatre utilisation rates, we rank in the top quartile nationally. So there's some real positive work in terms of supporting this agenda. Moving on to cancer, this is an area I was reflecting back when this report was presented 12 months ago, and we were ranking, for example, on most of our standards, the 31-day decision to treatment standard. We were 21st out of the 21 cancer alliances, so we were ranking the worst in the country. And similar position was for the 62-day referral to treatment. When we reflect now, we are ranking 6th nationally on them two targets. So there has been significant improvements, and when we see this month on month, we are meeting the faster diagnosis standard, Morecambe Bay meeting the 31-day decisions treatment standard. And I don't say that in a congratulatory tone, because there are still many of our patients waiting too long to get their treatment after referral. So there's still a lot more work to do, but I just wanted to acknowledge and recognise that the work that is happening in this area. Diagnostics is an area where we do not perform well nationally. We are in fact in the interquartile, bottom quartile, but there's a lot of variation in this area. And just to remind the board, this is a really important area because diagnostics in terms of monitoring conditions, which could be blood tests, x-rays, MRI, is really important for early treatment and treatment to plans for individuals. So across the 4 main providers, we have an aggregate position of 74.4%. Which is a deterioration from last month. So this means there are 25% of our population that are waiting longer than 6 weeks for their test, with the most pressured areas being non-obstetric, ultrasound and cardiology, where people are waiting, 4,766 people are waiting more than 6 weeks. So again, this is an area we do need to focus on, but there is significant variation across our providers. University Hospital Morecambe Bay is achieving the target and one of our better performers nationally, so the upper quartile performance. And Langs Teaching Hospital is one of the worst performing in the country. So that then levels out some of our performance across the region. There's a lot of work taking place in this space. Lancashire Teaching Hospital is a Tier 1 organisation, so there's fortnightly meetings with NHS England. There are improvement plans that are being monitored on a very regular basis. And before concluding, I just wanted to highlight a final area, which is mental health. There have been some changes to the way mental health metrics are now going to be reported. Still the same areas, but a different lens in terms of how things will be reported. So inappropriate out-of-area bed days will be replaced by inappropriate out-of-area placements. So there are currently, in the reporting period, 13 patients who are in inappropriate out-of-area placements. And as we've discussed before, this is a really important area, a national priority, is a financial cost, but more importantly, from a quality and outcome perspective, this doesn't do good for the individuals because they are away from their normal family networks. So I want to reiterate this is a national priority, and this year we have seen month-on-month reduction in the number of out-of-area bed days. NHS Talking Therapies has also changed the way that we'll be looking at its performance. So previously, the target was around recovery, and I welcome this change because this is now looking at reliable improvement. So just to make it clear for the board, where previously somebody who's really ill will score, let's say, 20 and they recover to 13 at the end of treatment, they would not be classed as recovery. They need to hit the target of 12 as an example. So reliable improvement, reliable recovery will really measure the effectiveness of the treatment that these individuals are going through. The national data flows are still being developed, but the local data flows are pointing towards all of them metrics currently being met on target by our providers. So I will pause there and I'm happy to take any questions with support from my executive colleagues with relation to their respective portfolios. Thank you.
Thank you very much, Asim. So, Kath and Chris.
Yes, so thank you, Asim. I think it's a really great report. And I just wanted to, live while I've been sat here, there's a request just come through about a multi-agency discharge event in relation to people with mental health who are currently delayed in hospital in Lancashire and South Cumbria. So we're identifying now housing colleagues, adult social care colleagues who can join that and look at that as a live issue today. So that's kind of the work in motion. And I think also just to recognise and to thank as well the recognition of all colleagues and partners' input into the maintaining and in some areas improving that not meeting criteria to reside. There aren't any of us in our positions who want anybody staying in hospital longer than they need to do. And it feels that there is an awful lot of work that's going on and some really good partner working. So I guess just on behalf of my Director of Adults colleagues, it's just to reiterate that commitment that's there from ourselves to continue to work on that. We know we've got a long way to go, but it's good to see that there are some little green shoots of improvement there.
Thank you. It's great to hear about the partnership working as well. Okay, so I've now got Chris next, then Aaron, then Roy, and then Sakthi.
Perfect, thank you, Chair. Just 3 points if that's okay, Asim. So just on for the board's awareness, so the waiting list information that we talk about is purely acute. So doesn't encompass neurodevelopmental pathway, which we know is some of our longest waits nationally and is replicated here in Lancashire and South Cumbria. I think just picking up on Kath's point around clinically ready for discharge, it would be good, I think, to see that pulled out more in the report and see that across providers and sectors, because it is a significant pressure. And I think when we talk about ED, waits, ambulance turnover, that's the barometer of the whole system flow. So I think it would be good to see that maybe just pulled out a bit. And then in section 8, it talks about My Trust not reporting against talking therapy. So we do, it's in our public board. So I'll link in with the SIM afterwards, but we are fully compliant with the 3 new metrics.
Just quickly come back on that. I think it's because of the changes to the metrics, the national flow of information still not ready. So it wasn't any sort of criticism of, of the trust.
I can share where we're up to
brilliant. Thank you.
Thank you.
That's good. Aaron.
Thank you, Chair. A couple of reflections, if I can. So grateful for ASIM kind of recognising some of the hard work that a lot of colleagues at Frontline are doing at the moment, and that's played out in a lot of the metrics, but not all. So a couple of points to make. It's clear that whilst you can see some of the work going into elective recovery, urgent care improvement, cancer improvement, we're spending over £100 million more in terms of the budgets that we have allocated to deliver that level of performance. And I think one of the things we need to recognise is, as we move into that transformation work and we're looking to recover financially, we need to find a way of doing that in a way that retains the continuous improvement that we're seeing on services. So one of the issues that I think has been raised before is that pace of delivery and trying to get to the transformation agenda and making those improvements. A lot of it is the complexity of making sure that we don't deteriorate or go back on some of the performance that we've managed to deliver, and that's one of the pieces of work we'll want to be doing across the provider collaborative and the ICB in this next phase. The second point I would make is the issue of variation. So ASIM very clearly points out that there's quite a bit of variation between providers, and being completely honest, we're not great at sharing innovation and the practice across the providers, and that's something we need to get better at, and a commitment, Chair, from the provider collaborative to do that also in this next phase. We do have tier 1 support and intervention, particularly at Lancs Teaching Hospital for diagnostics and cancer, and Blackpool for UEC. But for me, that's a failure of a system not trying to get to the areas that it can collectively without the intervention. So something that we'll need to focus on in this next quarter, Chair, from a collaborative perspective.
Thank you. Thank you very much. Okay, Roy.
Thanks, Chair. Just firstly to concur with Catherine, it's an excellent report. Thanks very much, Asim. Just 2 points I'd like to make. One on the diagnostics. That includes community diagnostics as well, those figures in there? Yeah. Yeah, because I think they're improving the diagnostics position across the whole of the ICB. The second one has been already discussed, actually not discussed, but commented on by Chris, on neurodiversity. Something that we've discussed in the Quality Committee. Thank you, Sheena. My concern about that is the numbers of the increase in assessments, and I think that's due to, although not entirely due to, we have a private unregulated sector, I think, providing some of these assessments, which concerns me, because this is who parents go to try and get these assessments, and no doubt, the numbers will increase if those are happening within the private sector, and then the individuals are then having to go into our areas like LCFT, which increases waiting times. So I'm just wondering, it's not something that we as a board can actually have any impact on, I don't think, but I think it's something that we should be making people at higher level, national level, aware that there is this sector that are providing these particular things for patients, and it just concerns me that does increase the pressure on us as providers of care for individuals who have accessed it through these other areas. Thank you.
Thanks, Roy. I'm going to bring Sarah in, then I've got Sakthi.
Thank you, Chair. Just responding to that, just for a bit of clarity, there are quite a number of non-NHS partners who will do an assessment for neurodevelopment in both children and adults, and we are seeing a growing number of referrals through. However, there is a regulation for a referral from, say, a GP or another clinician to get accepted. They have to be on a framework, on the Right to Choose framework. So even though we might not have oversight as much as we do with LSEFT or another NHS trust, they are on a true framework where they are there to be referred to. However, if we could tackle our pathways, which is what I highlighted earlier, and do the work that we need to do, we possibly would deliver some of this differently. And there is quite a significant financial risk for us through Right to Choose, which is something I have flagged before, and something we need to be mindful of as those referrals grow. I think it's an important thing to flag, but it's probably not as unregulated as you think.
Thank you, Sarah. Thanks for clarifying that. Sakthi.
Just an observation, and thank you, Asim, for the detailed breakdown of KPIs. We began this board with focus on reorientating ourselves towards prevention. And if you select those KPIs and examine how well we are doing from a prevention point of view, I'm afraid we may conclude that as a system we may be meeting the targets but missing the point. If you start with smoking at the time of delivery, red, vaccination coverage, not great, screening uptake, not great, influenza vaccine uptake, we've got a long way to go. And if you just carry on with just cancer as an example, we're not really good. And this includes the whole system working with the communities, in a sense, and with the wider partners. Cancers presenting in early stages are low, and the mortality is high. It just starts to paint a picture of KPIs meeting the targets, but actually this is costing us as a system, as well as the pain and suffering. But I just wanted to also extend that to say there is opportunity here as well. If you look at the data, the variation that Aaron, you mentioned, the same statistics, same KPIs are pulled out. If you look at the variation in the system, there are greens and as well as reds. So I just wondered how, given where we started the board, how we're going to get a better traction with how well we are doing in terms of preventing illness, misery and disease and disabilities. Thank you.
Good point. Aaron, are you coming in on that?
If I can, Chair, it's
Yeah,
a
please.
related
And
point.
then I've got Sarah as well.
And it might be in the same way that we talked about the SEND agenda and CYP, that how do we break out of the cycle of the short-term kind of focus alongside our desire to improve population health as a board. That might be worthy of a conversation. I'm just conscious, Chair, that we've got Lord Darcy's report into the diagnostics around the NHS due to land tomorrow. That's intended to be the platform then for the design and development of the new 10-year health and care plan. And one of the areas I think it would be helpful for us as a system to contribute to is the policy work that will sit alongside that, particularly the operating framework and our performance framework, because the system is designed at the moment to deliver exactly what it's focusing on, which is largely in-month, in-quarter finance performance from an acute perspective largely. So I think part of our role, if you will, in the next few months as we design that new policy is to create the conditions where actually not only is it permitted, but it's measured and it's focused on when we start to talk about those longer term measures, Chair. So I think there will be opportunity through the autumn to do that.
Great, thank you. Sarah.
Yeah, thanks, Chair. I wanted to make a similar point to Sakvi, but maybe in a different way around prevention, because I just wanted to draw our attention to the couple of paragraphs in the report on children's, and I won't repeat the points about neurodevelopment because they've been made, but even general community waiting times in particular for children often get lost, I think, in NHS reporting because it's not mandatory reporting. And, you know, we've got, it says there 500 children waiting over 52 weeks to be seen. There was a report published this week by the Royal College of Paediatrics and Child Health, which is really stark reading about the inequalities now for children versus adults. Children are waiting longer to access all health services versus adults. And yet, if we're really going to get prevention right, you would start in childhood, wouldn't you? And it's not just about, obviously, the things that we raised, vaccinations are key, but actually trying to see children timely and help them and support them is really important for healthier adults, which ultimately, as well as better outcomes, will save us a lot of money. So I do think we're not putting enough attention onto children. And when we get to the constitutional paper, you know, it reminds us that when the Act went through Parliament, there was a need to have a named board lead for children. That's because there was a recognition that children and young people with other groups, like people with learning disabilities, are often lost in when we've got lots to do versus the bigger agendas like urgent and emergency care and adults. So I just really wanted us to focus on that. But that report had a really stark quote, which I'll repeat, which was that children are, this was nationally, children are about a quarter of our population, but 100% of the future. And I think it's really important that we commit to focus on it. There is a speculation that the Darcy report is going to highlight children and ask for more of a focus on children right across the health system. Thank you.
Asim.
Just wanted to check. I want to come back on a couple of bits, if I may. Yeah. So Sakti, I think spot on in terms of your observation, and I think we do need to pivot some of the conversation and discussion around prevention and the list, Sakti, you went through around cancer screening, flu vaccination, smoking at time of birth. What we'll find, these are the areas where we'll find the biggest health inequalities. So we've done quite a lot of work around these areas where we see the differences. So we talk about variation here from a provider perspective. When you look at these areas, we'll start seeing variation from a population perspective. And I brought the flu vaccination on this agenda previously, that people from a BAME background, and if they're deprived and if they're a certain age, they are very less likely to have a flu vaccination. And potentially these are then the people and the neighbourhoods and the communities that might frequent the A&E department. So there's a lot of data we probably can look at to get better conversations at our committees and at this level. From a community reporting perspective, I think we need to also reflect that from an acute perspective, the data quality is stronger because all of the data reported is from national data sets. And currently we cannot do that from a community national data set because of the data quality. And we had a paper presented at the Transforming Community Care Board that described our community reporting strategy. And one of the asks on the back of that is to start reporting from national data set, but to be clear, in the absence of any national targets, what our local targets are going to be, in not just waiting times. So I think there's a piece of work we need to do as a board and subcommittees to recognise and acknowledge what targets we're going to monitor so we can then feature them in the report. Thank you.
Thank you. Very good discussion. Is there anything that we need to put down as an action against that, or is this all work that is ongoing? Great. Excellent. Thanks, Asim. Good. Still me. So, I think we're now going to move to the next item, which is the finance report, I believe. Yes, month 4 finance report. Sam.
Thank you, Chair. Okay, so we've got the finance report at the end of July, and I'm not proposing to go through the report, but just pull out some of the key messages from that, and happy to take questions. So, a third of the way through the financial year, the system remains aligned to the plan to achieve a deficit position at the end of this year of 175 million. Now, that requires quite an ambitious goal of delivering £530 million worth of savings across the whole system, and that's for us in the ICB and across the providers, and that represents 11% of our allocation, so it's a target larger than we've previously achieved. But there was and is and continues to be a plan behind that. So to meet that goal, what we agreed was that in addition to the usual efficiencies and waste reduction efforts, we'd need to implement some significant system-wide changes. It couldn't just be what we've always done before, and so we set out an ambitious plan around this, and I'm going to talk a bit more about that in the next paper on recovery and transformation. But given the complexity of those changes, we did anticipate a bit of a delayed impact, with the bulk of those savings expected in the latter part of the year. So at month 4, the system is broadly on track to reporting a £114 million deficit, and the variance stands at it's 4.5 million. Half of that is attributed to industrial action that we saw in June, and we're expecting funding for that. However, there does remain a risk of around 150 million to the plan. There's about 83 million in providers and 69 million for the ICB. And that risk is detailed further in the next section. But in response, we've implemented a process supported by NHSE to develop mitigation plans in case timelines do slip for the original plan, which could lead to a deficit in the range of up to 300 to 350 million if we didn't mitigate the last part of the year. The majority of that risk stems from slippage against existing plans. It's not about new pressures emerging. It's about us delivering the original plan that we had set up. And that original plan, a lot of that relies on us being able to de-escalate the UEC pathway, which is quite significant in the latter part of the year. So NHSE have come in to support us on reviewing current expenditure, variable pay, discretionary spending while we implement the changes that we need to see. It is crucial that the original schemes are delivered because the relying on non-recurrent measures, even if they do slip, we can't rely on those to support us in the future. We've got to make sure that we're delivering these recurrently to get into recurrent financial balance. So for the ICB, the main areas of the variance that we've got in terms of our own organisation is really around seeing some of the contract reductions we were planning and the pressures that we're seeing on continuing healthcare. Both of those are being really closely monitored, and we're targeting resources to make sure that we get those recurrent savings. The final thing just to say is really around the capital. We have seen changes in accounting treatment for leases, and that's put pressure on our capital programme. But it's more of a technical issue, and we're working with NHSE to look at how do we resolve the issue around leases, which are now treated as capital against our CDL target. So that's described in the paper in some detail. So I will go on to talk a bit more about the risk and the recovery in the next paper, because that's probably the main bit. But I suppose the summary on month 4 is we're on track, but it's largely, the savings are largely loaded towards the end of the year based on our original plan. Those plans still need to develop, and we're making sure there's mitigation in place to support that while those plans are implemented. Happy to take any questions.
Thank you. Thanks, Sam. Any questions? Yes, Aaron.
It's in support of some of what Sam was saying, Chair. I think as a provider collaborative, we've met collectively and separately on the finance position alongside some of the kind of the investigation and intervention work. Full commitment from all boards given, like I get separately and collectively, to achievement of the plan. The issue is not that there isn't granular levels of detail understanding what needs to be done, it's the pace at which that can be done, alongside some of the points I was making earlier around maintaining the service quality and the delivery. I think some of the work we'll want to do with ICB colleagues in phase 2, as we would call it, is going to be focusing on what can we collectively do at a greater pace to try and make sure we take advantage of all of the plans that we've got in front of us now. There is a reflection to give, which is all of our leadership teams now, the majority of their time is being spent in this arena, is trying to get us into the right place, and that isn't a sustainable model. So one of the things we'll also need to talk about, I think, through Q3 and Q4 is how do we leave behind the really good intervention work that's kind of improved the position we hope we will be in at the end of the year, but we extricate ourselves from some of that daily operational focus because there's big strategic and transformation programs that need some support. So highlighting that as a bit of an area of concern, but commitment from the provider collaborative to work alongside the system and getting to where we need to be by year end.
Thank you for that. I think that's welcome. I mean, it is going to be a very challenging few months across the system, and we've had a similar conversation this morning as an ICB. It's that ability to. We've got to get there, otherwise we're just not going to get any space. But at the same time, we've got to get there without forgetting the longer term. Okay, Kath.
Thank you, Chair. I think it's just to kind of just reiterate that the pressures are across the system. So for local authorities equally, experiencing significant financial impacts and have done for many years. So this isn't new territory, I think, maybe for local authorities. We've been digging deep and going down the back of the sofa, so to speak, for many years. So I think it's, what we've got is really close collaboration and how we work together. And I think more than ever, we've got to be really mindful of the decisions that we're making within our organisations, that one organisation is not then making a decision that has an impact on another organisation unintentionally. So there's something about us really finding that space to collaborate and work together before we make a decision, as I said, that could have unintentional consequences. And the impact is that we're just shifting the problem around the system rather than working collectively to find creative alternatives and solutions. Thank you.
Do you want to come back, Sam?
Yeah, thanks, Kath. I totally agree with you. And I think it's bigger than that really as well, isn't it? Because it's it's making sure that we're not cost shunting while we're all in this difficult position and we're working together. But actually, when we look at the transformation agenda, which we're going to come on to in a minute in the recovery paper, but when we look at the solutions to that, it absolutely requires us to work together on those, because it's about joining the parts of the system up. So when we talk about the UEC pathway, none of us can do that on our own. It's about us all joining together. So the opportunity in working together is huge. So I totally agree. Thank you.
Yes, Tracy.
Thank you, Chair. Yeah, I just wanted to sort of connect this a little bit to the previous conversation about workforce and how much our workforce really understand the challenges that we're facing as a system. And also, I suppose, thinking about what are the consequences of us not meeting this plan and how that is articulated and communicated to our workforce. Because I think, you know, it's clear to me that the consequences are very stark for our communities in terms of, you know, widening inequalities, in terms of, you know, really not meeting population needs around health and care. But what's the narrative around that, and how do we get that buy-in in terms of what we're trying to achieve here?
So I think that's really important, because it's something that we talked a little bit about this morning, but certainly in our thinking at the moment, with all this pressure on the in-year delivery, you know, you talked, Sathi, about the prevention agenda and about the long term, and we know that the solutions to this are not in year, they are multi-year over the next few years. So how do we do all this when we're trying to deliver that long term? And even more than that, your point, how do we communicate that to people? And I think it's really important to sort of think, and we've been thinking about this internally, and how we really sort of get this message across, but it's so important that we deliver the plan and try to get really on the front foot on this, because to get financial sustain, it's not about money, it's about the long-term sustainability of our services. And we can never get past holding budgets and pulling money back and doing the short-term stuff if we don't get on the front foot. So we need to create the narrative around this is about everybody playing their part, and how do we get everybody engaged in this to get that solution, because we talked about performance before. And although performance is really strong, we talked about 4th and 5th in the country and being really good on lots of performance indicators, how we're delivering that performance is not efficient and not good, and often it is really poor quality that we're seeing as a result. So taking corridor care, other things that we're doing, it's not good from a quality perspective. So if we can get people really galvanised around that, because that is what's costing us all the money in the system. It's all of this capacity that we've got that's costing. I mean, Aaron talked about the 100 million. That's what it is in the UEC pathway for things that aren't great for people. So how do we get that resolved quickly so that we can stop, you know, digging into our budgets and look at the long term and the investment? We've talked a bit about social care training and smaller things that are really important, but everything's being pulled right back because we can't get past this. So it is getting people galvanised around that message about how can they help? How can everybody who's either listening to this or here today play their part in helping us deliver this plan so that we can get on the front foot? And I think that's the narrative, and we'll need to take some time to think about how we articulate that.
Thank you, Sam. Really important. Sheena and then Chris.
Yeah, thanks very much, and thanks, Tracy, for that question, because I think, you know, you've hit the nail on the head. Is about how do we really engage everybody in this, so that it is around that ambition for something better for our population, and ensuring that we support people to understand in a very adult conversation around how can we first of all address need even more effectively than we have been, but also change that. And I think it's very helpful at the beginning of our meeting this afternoon to have that question on prevention and early intervention, because it is that bit around not creating a situation where people are suffering inequalities, are then needing to access care, and thinking very differently about it, and how do we really engage our population in those conversations. And I think, you know, Aaron mentioned earlier before about the Darzi report coming out, and I think it's going to be really important for us to consider that and the long-term strategy, but also your point about the operating model that goes alongside that. And I think it has to be very different. It has to be much less about, you know, sort of NHS institutions, and much more about really truly engaging across the system in an integrated way with all our partners, but also with our population too. So I think it's a great opportunity, and I think we need to think very mindfully about how we do that, and what our role is in doing that with people, not to people. Thank you.
Thanks, Gina. That's the key one, with people, not two people. Chris.
Thank you, Chair. So it leads on to what Aaron said there around, I think, we have got full sign-up, especially I can talk from my trust for this. I think all trusts will have started the year with a range of priorities that they wanted to focus on, and, our plan for this year had 20 priorities, of which we're making good progress on, but we have to refocus those priorities down, I think, for the next 6 months. So for us, it is around that end-to-end pathway of inpatient stay. And whilst we know there are patients that are waiting discharge, and for all the reasons we've talked about, the clinically ready for discharge, I know if I look internally, there's 40 beds that I could go at around 2 pathways where the length of stay, if I got that back down to average. But I think it's doing that with people, and as she said, and that improvement approach. So it's not, we can do the command and control and the grip and challenge, but that's not sustainable. We need to do this with people, with that improvement methodology, so that this becomes a sustainable piece going in, and then that lets us step back to do all the wider strategic things in the prevention area that we need to do. So I think that's definitely the approach that we're taking as a trust, and I know will be shadowed across the acutes.
Thank you very much indeed. Any other questions? No, so shall we then move to your next paper, Sam?
Thank you, Chair. Yes, so the system recovery and transformation. I guess our savings plans for this year have really centred around a quality focus approach. We've tried to do that from the outset. So if you remember back towards the start of the year, we talked about really looking at the savings and recovery and transformation programme in 3 key areas. The first one was really around reducing waste and duplication, and that would be through our normal SIPs, QIPs and savings plans, that we'd look at all opportunities for the taxpayer to reduce waste and duplication. There's lots of opportunities to do that, and we're all on and getting on with that side of things. The second area was really to improve and recover quality, and we're talking about things like corridor care in that space, but also some of the things that Chris talked about with OPES as well. So this is sort of where do we have things that are actually not great quality. We might be meeting targets, but we're not doing our best work through that quality agenda, and actually if we could address that, we can reduce the costs, whether that's through the urgent care pathway or through the OPES work that we need to do, and Kath mentioned housing and other things. So making those connections, we could actually improve quality and take quite a lot of cost out at the same time. And the third area is really that transforming the long-term clinical configuration. We've got a 1 LSC, but we've also got real opportunity to improve outcomes and create sustainable change, and this is where we want to get to longer term. I think this year what we've done is we've focused system transformation recovery in year on the reducing the waste and duplication and getting into some of that quality agenda. But I think while they take longer to deliver 2 and 3, such as the UEC pathway, a significant focus has been put on that pathway to look at in September and October particularly, seeing a real stepped de-escalation of the pathway to allow us to make those savings. I think the real risk with the recovery and transformation, and going back to the finance paper, is that sort of £100 to £150 million risk materialises after September and October if we can't make that stepped change. But that step change is really important from a quality perspective, not just a finance perspective. And I guess post-COVID, a major proportion of additional cost persisted in that pathway, and effective work has been done with place-based colleagues and utilising the urgent care boards, which I know is going to be the next paper when we talk about our urgent care strategy. We're starting to get into some of the plans that have emerged around that, and further work's now needed to translate those plans to make sure they actually go into tangible delivery. So current issues such as corridor care, escalation beds, delayed discharges are costing the system around £80 million and adversely affecting care. And the UEC delivery boards have submitted improvement plans in July, which are going to be talked about in the next paper. And what we need to now see is that impact in September and October. I think if it goes past October with the sorts of assumptions we're making in the financial plan, then it'll be very hard to pull that plan back before the end of the year. So our target, as we mentioned before, is to deliver 530 million savings in year. The current assessment shows it is an improved risk from the last paper we had. That 150 million is an improvement in terms of how those risks have been categorised. But the key actions remain to de-escalate and make sure that there's rigorous plans and implementation of tighter grip and control measures in place. So I just want to touch on the NHSE support and external review that we've got. So given the level of risk, because it is a backloaded plan and we do have a high level of savings to deliver, our system's been selected for support from NHSE. We've commissioned a 4-week engagement piece with a PA consultant who've been helping us to stress test those plans, assess the risks and identify the necessary interventions. And that review has really corroborated the level of risk that we've been reporting through the year and emphasising the need really to deliver Plan A, but in the meantime take some extra actions around grip and control to help us to deliver it for the full year. So additional interventions to help mitigate any slippage include things like focusing on any discretionary spend we've got, some variable pay expenditure and enhanced grip and control measures. They will include things like what we're finding is could we be better at using our rostering system or planning rotas, those sorts of things. Some of the grip and control stuff that we're talking about is that not just holding budgets, it's about making sure our processes are really good as well. So the current deficit assumes that a significant reduction is going to start in September. It is critical that we do that, but while we're doing that, and I think it's coming back to that conversation we just had really, we've got to make sure that while the in-year focus is absolutely crucial, that we maintain our momentum on the long-term strategy. So we are continuing work to sort of really develop our clinical strategy and the clinical configuration that we want to see, making sure that it delivers value for money, but really importantly improves the outcomes that we'd want to see and addresses health inequalities. And at the same time, from an ICB perspective, part of the work that we need to do to make sure we're fit for purpose of the future is just to make sure that our commissioning and operating models are going to support us to do that. So we're doing a piece of work around that. So we're continuing with the Recovery and Transformation Board, but it's going to oversee this real in-year focus whilst we continue to sort of make sure that those bits of work are in place to continue the long-term vision as well. So it's making sure that we do the two together. So that's, I suppose, an update on where we are with recovery and transformation, but you can see that it's probably quite a heavy focus on the in-year at the moment, but I just want to make sure, for all the reasons we just talked about, that we don't lose the long-term focus at the same time.
Thanks, Sam. Quite a lot in that update. And things are clearly moving very fast, which is as it should be. Thoughts, questions? Jim?
Thanks. It's really, I suppose, when I was talking earlier about the Finance and Performance Committee, I said I'd defer to basically what Sam was saying, but the committee were very supportive of this. I think it's almost the only approach we can adopt this, and it seems a really sensible programme. It was great to hear Aaron say that the Provider Collaborative Board members are all on board with this as well, but it's extremely difficult to deliver. And we're in that kind of delivery phase now. We really do want to see movement by the end of October, because if we don't, the consequences are potentially quite significant. But I think there was almost no other option than this programme. So whilst it's not by any means palatable, it's almost the only route we can go down, it feels like. And congratulations to the people who pull this together, because I think it's a very good piece of work.
Thank you. Thanks, Jim. Other thoughts? Yes.
First of all, Chair, thank you, Sam, and I just wanted to recognise the heavy lifting that's gone on in the system, especially by the executives across providers and the ICB. But I just want to follow up on it. It's a thought and a question that Jim, based on what Jim just said, and Sam's prompts. We are in the middle of September now. Based on what you've just said, if we don't deliver all this, start seeing the benefits by end of October, which gives us 5 weeks from now on, and Jim's thoughts about this is almost the only option we have, it just makes me think two things. How confident are we that this is actually going to be pulled off? And personally, not being part of the system, but knowing how difficult it is, I'm erring on probably it's going to be extremely challenging if you're lucky to deliver this by the target. But that leads me on to, so if there's no other alternatives, what are the consequences, and how are we preparing ourselves and the public to take them with us?
Little question there. Sam.
So I guess what we're seeing at the moment in a 114 million at month 4 deficit, and we've got to get to 175 at the end of the year, and that was month 4. So if it's a third of the way through the year, you can probably work out that that would be 350 million roughly by the end of the year if nothing changes. The step change that we've got in the plan is we're running at about just around a £20 million deficit per month, and month 5 is coming in on roughly in line with month 4, as has been, and we haven't got month 5 today, so I'm not reporting month 5, but early indications are showing that it's still in line with the previous months. The step changes then at month 6, September, and what we should be seeing is that sort of monthly run rate of about 20 million a month coming down to about 15 in that month, so it's a 6 million drop in month. That plan is actually based on that UEC de-escalation and other things that we want to see in the plans. What we've been doing with this sort of phase 1 NHSE support, though, is looking at what is the scope through holding discretionary spend, variable pay and other things. And what that does show, that is if we take all of those actions, there is a potential to pull that right back still. But really what we should be doing is delivering plan A. But we need to use some of that plan B to actually support us while we're getting plan A in place, if that makes sense. The drop again in October is quite significant, similar amount again. So we need to see some real step changes in September and October. It would need to be through some of those discretionary variable pay side if we can't do it through the plan while we get the plan in place. But that all of the providers are totally committed to that. They've all signed up to that and they're all working on those plans, but it's very, very challenging, and that's why it's high risk. It's not an unachievable plan, but it has a huge amount of risk in it, and we need to be really focusing on that. Now, what that's going to mean in terms of consequences for doing that is a lot of attention and resource and manpower is going into this at the moment to make this happen, and there are obviously consequences for all organisations about putting so much energy and focus on that. If we don't deliver it, it's that, you know, by October seeing that real change, it'll be very hard to pull back at that point. I don't know what may or may not happen, but other systems have gone into special undertakings and directions, and that is a potential that could happen. I don't know what the full consequences of that would be, but we're not there at the moment. We still are presenting a plan that we can try and achieve with some real opportunities to deliver it, but it needs everybody to grab it and deliver it. And you know, we're putting the message out very, very strongly that has to be done in September and October. So we did see a reduction in some run rate in August, but it has to be now stepped in September and October, if that makes sense.
Thank you. Thanks, Sarah. Yeah, sorry, thanks, Sam. I've then got Aaron, then Sarah.
Thanks, Chair. So it's the most oft-asked question, isn't it? How confident are you in the plan you put forward? There's absolute confidence that the efficiencies, the productivity gains and the financial savings are available to us. You can see the validation of what I would call the what, why, when and how. The issue is timing and how quickly we can get to the decisions and the structural changes we need to release those costs quickly enough to hit the year end. So for me, it's a question of pace and timing, not whether you're confident enough that you can see a route through to the delivery. I think we are going to face challenges, I think, through September, October about the phasing of how we're expecting some of this structural cost to come out. And speaking candidly, when we talk about savings of this type, it's the pay bill, it's the capacity. There are very clear levers that we need to pull for this to happen. And I think, Chair, one of the things we need to consider, and it's to Kath's point about cost shunting, from a provider perspective, that value in urgent care has to have real clear performance targets, oversight and support for primary care and social care. It is a pathway approach. We cannot deliver the capacity reductions that we're planning to do without that partnership approach. Now, I can speak for Morecambe Bay because we've got clear lines of sight on our urgent care improvements and the stepwise kind of improvement we use to close wards, take beds out safely and down to a demand change, nothing else. But we do need, I think, to consider with Craig, Sam and others, what's the framework, the operating model with cross-partner contributions required for these costs to come out, but we need to do that quickly.
Thank you. Sarah?
Yeah, thanks, Chair. I suppose I was going to respond as well in a slightly different way to Sam, to add to what Sam said, because in a way, Sam, you responded with the formal consequences, you know, we may go into undertakings and that, and you kind of think, well, what does that really mean? I suppose for me, trying to put it into words that maybe our staff and our communities can understand is, I think, you know, we're going to have to, it's a huge amount of savings, which of course you can't do without having to make some really difficult decisions about where to spend the limited resource we've got and where not to spend it. But I suppose if we can do this ourselves, then we collectively, who understand the local communities best, in partnership with local communities, can make those decisions. If we don't achieve it and we get some sort of formal intervention, it's probably no different, because you're in local authority, to when commissioners are sent in to a local authority. Somebody else who isn't wedded to the local community, who doesn't know it the way that we all do, and more importantly the way our communities do, will make those decisions for us. And I think for me that's the most concerning consequence of not doing this ourselves.
Thanks. Kevin, I'll just bring you in at the end.
Look, I think it's a good report. It's a difficult subject, isn't it? We've got a good plan. We know it's high risk. The main challenges are around implementation at pace. But it's also about psychology. It's about using this opportunity, actually seeing it as an opportunity, not just a problem. Seeing it as an opportunity to actually look at some of the things that in normal times would be too difficult to do. But this is a good time to do it. But it's also about trying to be positive, actually, and work as a team within the ICB, within the system, within the health system, and within the health and social care system as well. Even though there are going to be stresses and strains, and there are going to be difficult conversations between all of the partners, that's life, isn't it? But if we can have those difficult conversations, because we have to, but actually still retain the relationships because we need to, and our residents and patients deserve that, don't they? So I think it's really, it's the psychology and the culture around this that I think are going to be most important.
Thank you. So we now come to item 11, which is for decision, and leads on seamlessly from the previous discussion, which is the urgent and emergency care 5-year strategy, 24 to 29. Craig, you're going to take us through this, aren't you?
Yes, thank you, Chair. So thank you for the opportunity to bring this strategy. This paper actually covers the strategy itself and the strategies included, and I'll run through just the highlights because I'd rather get into the discussion. But also, we've given a little bit of a flavour of the engagements of the strategy, so it's not just been written in a darkened room by urgent and emergency care commissioners, but also the support we've had from PSC on some of the diagnostics, and that sort of links to the final bit of that last conversation about implementation and delivery. So I'll just capture that at the very end, because that's about our improvement plans. So the UEC strategy was a part of the rolling programme. So that was about developing a UEC strategy, having a rolling programme of improvement, and having more flexible governance, shall we say, so we could act and make decisions in a different way. I just wanted to say to start though, and it links to Asim's point, that there's been some real successes through our urgent care, not just to mention our performance, and that's not to be congratulatory or pat on the back, because that's been under extreme challenges, and you know, and I've constantly mentioned here us achieving a 70%ish target compared to where we used to be in the high 90s doesn't feel like we should be, you know, describing success, but it is, and it's in the context of a period of unprecedented industrial action. But also I think that, and I think Sarah's mentioned this today, the dedication of our frontline health and care professionals in delivering this is really, really important. We've also developed a whole range of other services, our community response, our same-day emergency care services, as well as Home First. And it's all about that personalisation around the individuals. So I don't want us to forget that as a part of the sort of one of the drivers for the strategy. But I think to put into context, we have an urgent emergency care system that won't be fit for purpose in the future. If you just look at the demand between 18-19 and this year, we've seen 19% demand in the usage of our urgent emergency care services. Nationally for England, it's 6%. So there's a 15% variance in growth for Lancashire North Cumbria. And part of the diagnostic work is to understand why is that, what's driving that, what's the difference for us. This is also about future-proofing, because we're expecting potentially £250,000 growth by 2033 for our population. So there's a real burning platform here to do something different. So, as I said, the strategy is here, and there's been ongoing engagement, and the engagement, I'm not going to read through, but is in the covering report. But there's a clear case for change in the strategy, and it starts to talk about our opportunities for improvement. But when we started engaging on this, we wanted to everybody understand what our vision was really for urgent emergency care. And that's about a system, so that's all of us, that enables people, so our residents, our patients, our population, to easily access the right care and support at the lowest level of intervention to best meet their needs and deliver best outcomes that are affordable. But those needs can be met. And some of them will need hospitalisation, some will need specialist services. Our 5 aims that are underpinning the strategy are about adapting our urgent care system, as I said, to be fit for purpose, ensuring that people have high quality, safe and affordable care that's in the right place, enhancing our preventative care that lends itself to Sakthi and Sarah's comments earlier, and also to address the needs of our local communities. So where we can do things out of hospital with people in communities, it's really, really important. Embrace our opportunities for innovation, and we've talked about some of that digital innovation and some of the things we need to do really radically different. So the strategy talks about the case for change, as I've said, and starts to go through all the different opportunities. But I think some of the commitments we've tried to talk about in practical terms are about expansion of our out-of-hospital urgent emergency care services, expansion of the services in the community that people can access before they need an urgent emergency care pathway, the redesign of some of our integrated UEC services, and then it goes into, well, what does that mean for the hospital front door, our A&E services? How do we improve flow through the hospital? And often that isn't just one silver bullet that you can do and it just flows through the whole system to make it better. There's workforce challenges, there's challenges about the different demographics, there's challenges about needs in our communities, which was what drove us to developing urgent and emergency care delivery plans that were wrapped around our places. And that's the support that we've had through PSC, understanding the diagnostic work, but saying, what does that urgent emergency care improvement plan look like for Lancashire? What does it look like for Morecambe Bay? And we've been working very closely with our providers to develop those plans and our places. And that, I think, is the bit where the magic needs to happen and the successes will start to see come to fruition. Because if we're going to change how people access services and then travel through our pathways for urgent emergency care, Aaron's absolutely right. That's not just about how the hospital or NWAS manage people being conveyed, or how quickly someone has a length of stay, or how fast you can get them discharged to CAF. It is more than just that, because we've got to think about it in its broadest sense. So we need to make sure our plans think about that prevention agenda, think about individuals that aren't necessarily accessing services through our emergency services, are walking to A&E. What's driving some of that? Is it about not having access to GP appointments? What's understanding that? Is it about a lack of GPs in that area? And that's where some of that layer of diagnostic understanding really needs to be brought to life. So we've been doing the work on the urgent emergency care plans. We know we need to improve length of stay. That's one of the commonalities. We know that we need to look at our workforce modelling. That's another common thing across all of our providers. We know that we benchmark high, and you just heard some of the figures that are mentioned, and we are extremely high compared to the national average. And we know that some of the root cause analysis are related to things outside of even the NHS or the hospital system. So having those bespoke plans that can address those needs are really critical, and those plans are now in draft form in the main, and we will be signing those off through our local governance. So what will be different? Well, this strategy is aimed to redesign our whole offer for urgent emergency care, look to provide services in a different way, where we've got great services, preserve them as best as possible, but also make sure we're future-proof, because we know over the horizon that demand is not going away. So we need to make sure we get the best out of our investment and that we are improving the quality and outcomes for our population.
Thank you, Craig. Thank you very much. So I can see some hands already. Jim.
Thanks. First of all, I think that it's fascinating to see the place plans and how different they are, and that one size doesn't fit all, and that's kind of really important to know. And I know the aim is to optimise care for all patients, but it's different in different patches, and I think it's really good that we got that level of detail, so that granular level of detail. So I think that's really fascinating. The 5-year strategy, I was a bit critical of last time we looked at this, around the fact that there was very little measurables in it. There is now measurables. Personally, I think it would be helpful to show the start point for these measurables. I also think it's important that the items where you say what this will mean for our population, there's a link between those and the metrics you're using. There is some gaps at the moment. So there's some things listed in what the improvements people will see, which will not be measured, and I think we do need to kind of bridge that gap, basically. But apart from that, I think the strategy makes sense, but it's short term, it's delivering those place plans, and we've already talked about the fact that they probably need a bit, not more pace behind them, but the challenges Aaron's talked about previously about delivering it, the hurdles we've got to get over to deliver them, we need to collectively work on that as best we can, really. And I think we're all behind it, but it's just making sure they happen.
Thanks, Jim. I've got Sam and then Sarah.
Yeah, thank you, Craig. I just wondered whether, just to sort of connect it to what the last couple of papers really around the finances, those plans, they have had, I mean, as well as having a really good diagnostic around them to really understand what's happening, they've been driven as well by our place leads, which has been really good. So if I took Morecambe Bay as a good example, we know our place director in Jane Scattergood has worked really closely with the trust, and I think it's been broken into three, and Kath as well, and broken into three sort of key areas as far as I'm aware, which is around sort of what the hospital can do themselves in that pathway, what could be done sort of out of hospital in primary care, and then the other sort of out of hospital part. So I didn't know whether, I'm putting Aaron on the spot a little bit, but whether Aaron could just connect that for us on the money. So when we were talking before about a drop down in September and October, that would be a good example of how that particular plan is helping to do that for Morecambe Bay.
Aaron?
Happy to do that, Chair, and it will allow me just to make the point rather than pose a question, if that's okay. So this is very much in that cause and effect and understanding what the actions each partner is going to take to release benefit. And I will say that it is benefit in the round, so it will lead to shorter waiting times, easier access through urgent care. But we describe it in three buckets. You know, the kinds of activities that each of the partners needs to do together. It means each partner takes a lead role, but it also means you've got cross-partner working in each of them. Whether it's the in-hospital transformation programmes around same-day emergency care, frailty, some of the urgent treatment streaming that we've got. With social care, it's about that really considered view of not cost fronting, but talking about how we discharge safely, and together how we integrate our discharge teams, essentially. And then working with primary care around how we manage demand, including streaming at the front door and greater connections with primary care. So it sounds very easy, but it is as simple as just sitting together and agreeing together what are the core deliverables for each of us, but then holding each other to account. There is an accountability piece that sits within the Bay that we do reasonably well and don't fall out, do have the difficult conversations, but the relationships are still strong. But whilst it's a package of benefits, we can't shy away from, and I was interested in it didn't feature in the strategy. We've said there's £80 million available in the UEC transformation programme, but it doesn't feature in the strategy prominently. I think we need to be honest about one of the measures of success has to be reducing the amount of expenditure we have in the urgent care system, because those actions that release these benefits for patients release cost. So I'd be keen to see a trajectory for the strategy being deployed that releases the 80 million, because it'll help us with that cause and effect. Yes, that was the point I was going to make.
Thank you. Do you want to come back on that, Craig or Sam? I think we'd be quite enthusiastic about that, wouldn't we? Yeah.
I mean, that would be an absolutely essential part of it for me. But I think we've probably got that, but it's not written in the strategy. So I think you've been looking at this through the lens of that cost as well as from a quality perspective. So I think it's how we've been able to try and join the two together. But I agree, it needs to be more explicit in there.
Great, thanks, Sarah.
Yeah, thanks, Chair. There was a couple of points. One was probably has already been made, but so I won't say a lot. But I think it's a good strategy when it interconnections to other strategies and other pieces of work that we're doing. And I think one of the challenges will be making sure we keep all of that connected and we're really clear on who's doing what and when and how it all links together. My other point was reflecting on the quality standards, which I had seen before, but I suppose with the patient story in mind, but also I was reading something last night that was sent to me from our patient experience team, and they'd collated some narrative around urgent and emergency care, and it's really powerful. I'm happy to share it with board at some point. Really emotive and really powerful, and I felt a little bit that, you know, just saying we'll look at satisfaction scores for patient experience is probably not strong enough, and I think it's really, really important because urgent emergency care is such a national challenge that I think we always look at it through a performance lens, you know, 4-hour waits tick, done this tick, and actually I think it'd be really, really powerful if we can mix some of the some qualitative measures into this around from a person perspective, maybe some I statements or something, because when you read about somebody's 15-hour wait on a trolley in a corridor, you can't pick that up on a friend and family test or what that meant for that individual or for that family. So I think my thing would be to add to this some more patient-focused measures around that quality. And similar with mental health, I don't think the mental health measure of an assessment is when we know long waits in mental health is another national challenge again, and it's a challenge in Lancashire and South Cumbria. So it's a plea really for us just to maybe add a little bit to some of those quality measures.
Thanks, Sarah. Chris.
Thank you, Chair. So I've just got 3 things just to bring up, if that's okay. So I think it's really good how mental health's woven through the strategy. I think, you know, and it comes through that it is a integrated urgent care, not an acute integrated urgent care. So that's really positive. I think when we talk about risk, we need to think of risk wider than A&E. So there are numbers of patients today waiting for an inpatient bed, be that physical health, but predominantly from my perspective, from mental health, at home with home-based treatment teams waiting an inpatient bed, and we need to see risk wider than A&E and an ambulance handover, as important as they are. Yeah. And then my last point was just on, we talk about one of the metrics, and I suppose it's the ambition first around the metrics, to what? But then when we talk about mental health assessments and reducing those times, we're 100% within Lancashire and South Cumbria within 4 hours for mental health assessments in A&Es. 95% of patients get assessment within 1 hour within A&E. Assessment is not the issue. Flow and through into an inpatient bed is the issue. And I think if we collectively, as Sam's talked about before, get behind this, that will have huge benefits from a patient experience, but also from a financial perspective, enable us to step back and then do that wider strategic transformation we want. But a really good start, thank you.
Thanks. Thanks very much, Chris. And Kath.
Thank you. Yes, honestly, I think it's great to see it all pulled together, and I just want to say thank you, Craig, because it has been a really collaborative piece, and I can see words of colleagues that I've worked alongside that's in there, and I think that the place-based directors have been absolutely key in kind of getting hold of this and leading this, has been able to pull it away together in a way that perhaps hasn't been pulled together previously, and having that different view about the different places. So whilst the principles of what we want to achieve are the same and the vision is the same, how we deliver it in our places will be slightly different because of the different makeup of those places. So I just wanted to congratulate you on that. I think just in terms of the patient stories or people's stories, happy to contribute to that because we're already starting to gather a rich sort of feedback in relation to things like the impact of intermediate care and stuff like that we've got in Westmoreland, in South Cumbria that's coming out. I think the beauty, and I'm only picking up on this obviously because it's my particular area, I'm the director for Westmoreland, but I think we are really proud that we've got such a simplified plan. It's 3 circles on a page that can be shared and explained to anybody very easily what it is it wants to achieve. And the quality impact in terms of that being on any one day, 150 people approximately across the patch who are delayed in hospital, not being delayed in hospital because actually there's other alternatives for them and the plans are there and plain to see about what will do that. But there's something, isn't there, as well about the not meeting criteria to reside isn't just about when you get to day of discharge, it's actually before you even come into hospital. So where we know we've got those elective surgeries, for example, and Mrs. Miggins is coming in for a hip replacement, I've got a wealth of stuff and people that we can tap into, working really closely with voluntary community teams about what can we do to support Mrs. Miggins that means at the point of discharge she doesn't need regulated care at all. Actually, she's got a plan in place that can support her to be discharged. And I guess just at the thinking about the financial efficiencies, and we've got to do it as well as a local authority, this is why we need to do it together, is it's important to identify the savings, but are they genuinely all savings? Is this about reinvesting in the things that we need to do differently that are going to make the difference for the longest term? So I'm looking at Tracy when I say that because that's about our voluntary community faith sector, really investing in that long term to be able to drive some of that activity that happens before somebody even gets into hospital in the first place. But yeah, really happy to support you.
Great, thank you. Craig, do you want to come back on that? And then I was going to bring Kevin in to finish.
Yeah, thank you, Chair. I think the comments on bringing it to life with some more of the patient or people-related stories that we can add in, I think that's a good addition. And take Jim's point about some of those metrics in relation to the outcomes. We'll go back and just make sure that they're articulated in a way you can see if this is what we're measuring, what is going to be that benefit. I think the £80 million savings absolutely we can put into the strategy is in our commission intentions, and I think if we want to put it in the strategy that's absolutely within our gift, so of no issue there. And I think we'll just look at some of the metrics, especially in relation to mental health, just to make sure we've got those absolutely spot on. But yeah, really helpful comments. Thank you.
Thank you. Thanks very much. Kevin?
Yeah, I think it's been a really good discussion. It's a really good piece of work, and I think it sets some foundations in place to do even more of this going forward. We had a full day, I think it was on a Friday sometime in July. It was one of those rare days where the sun actually did appear. And you know, what impressed me about it was, well, first of all, it was a joined-up approach. You had people from the councils, you had people from primary care, you had people obviously from the acutes as well, and place was at the centre. But actually they're not, this is not based on the place footprints, so we're calling it Place Plus, because you've got to look at the hospital hinterland. And people have adapted to that, which was really good. It's backed by really good data. And what's impressive here is it's a sort of fusion of population health-based data and really granular finance data as well, which I think was quite powerful. I think there's maturity, and we need to grow that, develop that further. So, you know, historically, we've always had a bit of an argument between the hospital and the outer hospital sector blaming each other. And I think what was here was we could begin to see how much of the problem was in the admission space, how much of it was in discharge, and how much of it was in the hospital and which parts of the hospital. You know, so it's really, really quite powerful. As Jim said, no one size fits all. I mean, essentially, in simple terms, East Lancashire, the big issue there is admissions. UHMB, the big issue there is discharge. And in Blackpool and Preston, it's a combination of the two, really. So And I think that's great. That's real place making, isn't it? Because it's sort of getting into that granular detail. I do think, though, the biggest issue going forwards is to really get this going and build on it is admission avoidance and working with the primary care sector in the broadest sense, obviously general practice, but pharmacies and all the other partners, to really try and arrest that 13% growth in admissions going forward. And there are lots of great schemes. The Fleetwood scheme is one gets a lot of PR within our system, and it's had national attention, and they get great results. But it's doing that on a big scale and really looking at the opportunities to do that going forward. And if we do that, we've really got to focus on the frail, elderly and deprived communities, because that's where the bulk, therefore it makes a big difference in terms of inequalities here. So for me, this is a great piece of work. There's a long way to go. We are at the foothills of the mountain, but actually this is what Integrated Care is all about, isn't it?
Great, thank you. Thank you very much, Kevin. So I'm taking it from those comments that we are happy to approve this. Excellent, thank you. Great piece of work, Craig, well done. It's good, in fact, everybody. Okay, so now we have item 12, which is implementing updated Integrated Care Board Constitution and Governance, that thrilling subject. Sarah.
Thank you, Chair. I'll take the paper as read, and I suppose what the paper does is highlight. So obviously, just in case anybody wasn't clear, we have to have a constitution underpinning the board and all the work that we do of the committees. It's based on NHS England guidance. So NHS England have updated their guidance, and what this paper is doing is highlighting to members the points in the guidance that have changed and what additions what changes we would have to make to be compliant with that. In addition, last year, if you remember, because we did bring it through board, they published some guidance on having named executive lead roles for certain things, so like children and young people. They've now made that part, instead of that being a separate document, they've attached that to the Constitution guidance as an appendix. The paper highlights that and explains how we've addressed that, and the paper also is recommending some changes to our conflicts of interest policy in light of all of this. I need to give all the credit to Deb for all the work on this, both in terms of developing the constitution and then looking at the updates. And I think the paper really flags that we haven't got any there's no significant material changes for us here or work to do, because I think the work that was done when the ICB was established was very robust. So I think that's all credit to Deborah and the team. So the paper is asking you to note the changes and all in the guidance, support the review that's proposed of the conflict of interest policy, and approve the amendments as they're outlined before, because we have to then submit our updated constitution to NHS England for approval. Thank you.
Thanks, Sarah. Are we all happy to do that? Thank you. Thanks very much indeed. Okay, so we have one item to note, which is a review of progress against the ICB and the Voluntary Community Faith and Social Enterprise Alliance Partnership Agreement. Is there anything you wanted to say on that, Craig?
Thank you, Chair. This has been very much led by our Director of Partnerships and Collaboration, Jane Cass, but also support from voluntary sector leaders, of obviously which we've got one at the board. So I'll just pass over to Tracy in a second just for any comments. I think it's better to hear from the champion and one of our leaders in the sector. But this is an agreement that we signed last May, as in May 23. The agreement sets out our conditions for a productive partnership that I think is working really well, and the paper obviously summarises the recommendations against the progress. I think significant areas to note are the increased voice and leadership throughout the sector, a range of ICB committees and discussions and influencing and shaping our policy and decision making, investment in the sector to support infrastructure. They've done some testing of proof of concept through more strategic commissioning, through the Alliance, and obviously real critical offer in relation to urgent emergency care and our winter monies. So some really great, I think, successes to date in the last year. The next steps for focused attention are more consistent approach across all of the organisations, because it's quite challenging navigating through the richness but also the volume of them, looking at where we can support the future viability of the sector. So that's not just about the finances, but that infrastructure support and what we can do in relation to partnerships and collaboration, and what that means as being an equal partner with the ICB, and also the next sort of version of the Alliance and what that means for collaboration across the sector and our strategy of the future. So I don't know if Tracy wants to add anything to it.
Thanks, Craig. Yeah, you would expect me to have a few things to say on this, wouldn't you, really? Yeah, like you, I just want to pay tribute to all the work that's gone into pulling the agreement together initially, and then all the mechanisms that have helped us really enact some of what we put together in this agreement. So particularly Jane Cass and Claire Roberts, but also you know, lots of leaders across the VCFSE sector, not least Jo Hannett, who does a lot of work behind the scenes to make some of these relationships really work. I just want us to think a little bit in the context of this meeting and the other things that we've discussed today around some of the things that I consider to be kind of essential in terms of us working in partnership. So I just want to think about what the VCFSE contributes to this agenda. So, you know, we keep people well at home. So we support people to change their lives for the better. So better housing, increased income, better access to volunteering, and better social connections. And I think it's really important, because we've talked about the prevention agenda at length through almost every agenda item today. And, you know, we talk about those wider determinants of health and how important it is to be addressing those, not least when we talk about the UEC work. And I'll say a little bit about what we're doing on that in terms of this partnership agreement. But I think, you know, in order to kind of work effectively and meaningfully in partnership, then I've seen some really great examples that have come out of us really agreeing a format to this and the way of doing things. But there's also some challenges ahead of us. So I just want to pick up on some of the positives and then maybe just cite you on some of the challenges. And Craig's already mentioned some of this. The UEC work and the way in which we as a system made a decision to top slice some of that budget for the VCFSE is absolutely a byproduct of this partnership and on our the way in which we set out our stall to really think about more innovative ways of working. And I think we haven't seen the fruits of that yet. It's in its very early stages, and we're just starting to, as a partnership, allocate that funding into places where it can really make a difference. So we've got some work in and around Blackpool and Blackburn where we're absolutely, you know, as a sector, working on ensuring that we keep people away from the hospital doors as we go into the winter. So it'll be really interesting to come back again and see how that's all developed. I think also the work we've done around data and digital with Asim and his team around looking at how we come together and overlay some of the data that the rich data we have as a sector, and make sense of some of those health inequalities so that we can better plan services. Again, in its early stages, but I think you'd agree, probably wouldn't have happened if we hadn't had that partnership agreement in place. I think as well, the building of relationships has been absolutely fundamental to this, and that representation and voice that exists across our system is quite unique. I think there's still a lot of work to do around that, but we have a really clear blueprint of where we have sector leaders across our system and understanding where they're making the difference as well and where they add value, I think is again something there's been a lot of work on behind the scenes. Some of the work we did around system leadership as well, Deborah, that you know, I think again, you know, and Sheena, looking at how we work more collaboratively, but also looking at how we develop our system leaders across the sector as well, I think has been a really great initiative, and something again that came out of that working in partnership. I think some of the challenges going forward, and it won't be any surprise that I highlight this, is commissioning arrangements and the fact we haven't yet got to agreement around that long-term ambition of, you know, 3 to 5 years funding into the sector, we're still seeing quite a lot of short-term commissioning. We're still seeing a lot of challenges around payment systems and some of those, you know, really quite granular issues, but that are massive for us as a sector in terms of how we unlock the potential of what we can do around health and care. And I think also, again, looking at how do we really start to quantify where we're adding that value and where we really feel as though, as a sector, we are equal partners within this system. I think there's still some work and some progress to do around that. So thank you for giving it the space on the agenda today. I really appreciate that. I hope we carry on talking about the way in which we're working in partnership. I'm sure we will, because I think it's absolutely vital for many of the other initiatives that we've talked about that are going to transform our system. So thank you for that. Happy to take any questions.
Thank you. Thanks very much, Tracy. Thank you, Craig, for the paper. Any questions? Jim?
Well, very encouraging report, and thanks, Tracy. I think we all understand how important the sector is, by the way. So you were right at the beginning to tell us what you are doing, but you know, we know that, and we are very appreciative of that, I think. It was very helpful to hear you describe it and bring the thing to life. It came more to life, sorry, Craig, but it came more to life when you were telling us those stories than when I read the paper. Two things, really. How do we compare with other ICBs? Are we sort of, we should be, in terms of taking this forward, because it is, I think it is very important. And secondly, are all the NHS organisations participating across all the places, or is this kind of being done in patches better than some places better than others?
Yeah, no, that's fine. It's a good question. Good questions. Thanks.
Thanks, Craig. I think in the first question, I think really interesting question, where are we? I think other ICBs have concentrated a lot on the commissioning side of things. So I think we're probably a little bit behind when it comes to the commissioning side of things. But I think where we are being looked at by other systems is around that representation of voice, where we are, where we're developing those relationships. And I think also the investment from the ICB in the people to make this work as well is something that I think is accelerating. So it isn't always about investment in terms of delivering of services, it's investment in terms of giving me the time to be here, having somebody in a position to work with us as a sector in the way that Jane Cass does. Those kind of things, I think, really people look outside of the system and say those are really great ways in which we're going forward. As I said, more work to be done, but I think that we're ahead of the game on some of this work, and other systems are looking and saying, how have you achieved some of what you're doing? I think also, let's not underestimate just how important it was to sign this agreement in the first place. Some systems are still grappling with, what do we put in our agreement? How do we get both sides to actually sign up to this? So I think positive things there. I don't know, Craig, whether you want to pick up on the second question that Jim asked? Or?
Yeah, so there's no, I think all of the NHS organisations are involved, Jim. I think to varying degrees it's probably worth to say, so some are much more actively involved in parts of the work than maybe others are, but there's no resistance from the NHS with this. I think some of it is just about, so I think the UEC work actually has really been one of the ones where it's connected the voluntary sector, faith sector and social enterprise to the NHS and to our acute hospitals really well, and I think we're going to take the learning from that and see, Tracy's absolutely right, how we build that into our commissioning of the sector in the future, because it is on our plan, but as we've heard in the Recovery and Transformation, and as you heard in other meetings, we do need to focus on our commissioning and what we're going to do going forward.
Thanks. Sheena?
Yeah, just to really say, really great report and really helpful. From a personal perspective, I absolutely value the input that we have from the sector on the Quality Committee. I think it brings a really important dimension to all the work we do. And I think, in terms of what I've experienced is it's a very different approach than traditionally we've done in the NHS. So very, very important. However, what I would say is I think this is only a starting point, and I think we really need to be really clear as an ICB and also as an ICP, that we should have really huge ambitions for this, and we should really challenge ourselves to say, can we go, how fast can we go, and how further can we go? And I think it's also the fact that, you know, this is a really important way that we get to understand you know, what's going on in our population and bring that into everything we do. And I think that point about the commissioning bit is really important. So thank you.
Thanks, Sheena. Roy.
Thank you. Well, I can certainly remember, Tracy, in Blackpool when the voluntary sector just relied on grants and, you know, pulling it together with bits of money here and there. And I think, you know, the work that's gone on incredibly has been focused and brought together by yourself, because it was a disparate organisation, I think, earlier on. That's, I say, been brought together with your tenacity and hard work. You know, I can say I'm you know, it's not a backslapping exercise this, but you know, I think we should recognise that, because without the voluntary sector, I think we're certainly struggling in certain areas. And I think without the money we're providing to you, instead of having to, you know, go around with a begging bowl like you have done in the past, I think that's been helping you to bring some of that work to life. And I congratulate you on that. And I think all the board will do as well. Thank you.
Thanks, Roy. Okay, Kevin, I think you wanted to come in at the end.
Yeah, thank you, Chair. Good start, long way to go. And sometimes the NHS can be a tricky partner with lots of short-term contracts, sometimes challenging procurements, and sometimes we medicalise things we shouldn't be medicalising. And, you know, so I think we're not always the easiest of partners. So I'd like to thank Tracy, Joe and Angelus and the other leaders for being patient, for being constructive and positive, because I think we've got something special here that we can build on. I think the work we've just looked at in UEC is an example of some real material progress. I've seen some brilliant examples, and Emma, when you do your induction, you know, you should talk to Tracy about some of the things you can go and see. One of the ones was something called The Well in Morecambe, which does work around people with really complex drug addiction, with people who've got lived experience. That's the offer. And there's a really good connection with primary care, you know, and signposting people to those services. So it is really building into the NHS system in a really positive way. End of life is cited in the report. There's a lot of opportunity, I think, to do a lot. We've still got over half of planned deaths in hospitals, and I think the voluntary sector could play a real big role there. So again, it's one of those things where we are at the foothills of the mountain, but I think we've got the seeds of something special here and we should build on it.
Excellent. Thank you all very much indeed. That's a good way to end. So, is there any other business? No. And I've got items to the risk register. I'm assuming that most of the items we've discussed are, yep. So just a couple of closing remarks from me. It's my first board meeting. I've really enjoyed it. I really appreciate the openness and the level of engagement around the table. And it's clearly a system and partners that work closely together. I'm sure that not all conversations are always incredibly positive, but that's because the issues that we are dealing with are really, really intractable and really challenging. But thank you for your candour and your engagement today, and I'm really very much looking forward to working with you over the next months and years. Thank you. Could I just ask board members and partner members just to stay on? We're finishing just slightly early. I always like to do a little bit of a